Hello, my name is Frank Caputo and welcome to Health Comes to Mind. This will be a series of 6 programs which will address various areas that will hopefully explain that there is a connection between the mind and the body, which for a long time in Western medicine wasn't recognized, but is now. And over this period of time, hopefully we'll be able to supply you with some information that will allow you to realize that there is a connection and things that you might be able to do to assist you in areas such as addiction, relationships, physical illness. We thank you very much for being here, and we look forward to spending some time with you in the next 6 weeks. Thank you very much. Hello, welcome to Health Comes to Mind. I'm Frank Caputo. My guest tonight is Donna Marrero, RN, who is the hospice coordinator for Bristol Hospital. And since this show has to do with the connection between the body and the mind, Donna deals with, I'm sure she'll get into more detail about it, people who have physical illnesses, but there's also an emotional component of that illness, and hopefully we can come up with some connections on that tonight. So Donna, can you just kind of tell us what hospice service is? What you do?
Well, hospice is a service that can be provided in many places. It can be in the home, it can be in a hospital, it can be in a nursing home. Mm-hmm. And what we're doing is we're providing end-of-life care. Patients that have an illness that is terminal or chronic illnesses that are causing them to have a decline in their life need some supportive services. So it's basically a whole philosophy of having the rest of someone's life be with comfort and dignity. Mm-hmm. And we have a variety of people that in our agency can provide this support, and it's not just the nurse alone. It ends up being a variety of members of our team that care for patients. It's a whole philosophy to make sure people have some dignified life, some peace at the end of their life, but they're also trying to, we're trying to find a way to have quality in the last part of their life. Mm-hmm.
Mm-hmm. Yeah. You know, when I first heard the word hospice, I have to tell you that Donna has provided services in my family, and when I first heard the word hospice, even though I've been working in healthcare for a long time, I think, oh, it's that place you're going to send somebody to. It's that place down by the shore, you know, you go there to die or something. And that's not what it is. It's not a place. It's a service. It's a concept or whatever you're talking about here. Right. Right. So if a person is diagnosed with terminal illness or disability, disabling illness, that would not allow them to do anything without assistance or whatever the case may be, what would be the criteria for them to say, we think maybe you should get hospice services? At what point?
Well, you'll have a certain diagnosis that it doesn't have to only be cancer, and that's the misconception. You have a lot of patients that have disabling illnesses that can be some of your cardiac and lung diseases that can be disabling, even people with dementia, Alzheimer's. Some of your neurological diseases. There's a lot of disabling diseases that cause people to shorten their life. The supportive service is to try to help give them some quality, but it also provides the service to control their symptoms, to keep them safe, keep them mobile, and remind them that they're still alive. There's a lot of disabling symptoms like pain, like breathing difficulties that can alter their functional ability and certainly not give them comfort. When they come on the hospice service, we have experts that know how to control those symptoms, whether it's shortness of breath, pain, it could be any kind of, whether it's skin breakdown or nausea, inability to eat, things like that, that can really cause them some distress. But the hospice experts can really anticipate their needs as well as provide that comfort to them.
And to the family.
And to the family.
Right. Because I know people are not sure what's going on many times. Why is my mother doing this? Why is my father doing that? And you'll be able to come up with some of those answers and maybe able to help them to deal with that too. Because you're not there 24 hours a day, but you might be able to help the people do what they have to do in order.
Right.
And because, you know, me as a lay person, when it comes to any clinical thing like that, I wouldn't have the slightest idea as to what was going on. Why is this happening? Why is this happening?
Right.
And you're the person to ask as to why that's happening.
Well, you know, the nurses certainly have a lot of that information. We end up being the eyes, ears, nose of the physician, where they're representing them. Any kind of hospice care is covered by a physician. They are the ones that order hospice care, the medications, any kind of treatment that we provide. But the nurses are the ones that are there witnessing the changes in the patient and the family's condition. But the other members of our team are very instrumental in helping the patient and the family. We have social workers, we have spiritual counselors, chaplains, we have a bereavement coordinator, and we have nurses' aides that help with more of the personal care. We also, with our social worker, they're able to identify other possible services in the community that can be an adjunct to what hospice provides. They can provide some counseling to the patient and the family. We're trying to anticipate what their fears are, anticipate what their questions are, and try to provide the answers as best we can to them.
That's very interesting, because you know, it's not just, I guess, you know, years ago it was there's nothing we can do for you. That perhaps means nothing we can do for you to cure this or reverse it, but there are things that you can do for a person that's in that position, and hopefully, you know, you're the people who would be doing something about that. See, I never liked that song, by the way, "Live Like You're Dying." I don't think you do either.
No. Well, I mean, the issue with that, what it's telling you is if you're suddenly faced with this life-threatening illness, you know your life's going to be shortened. We all know we're going to die someday. We just don't always know when.
Right.
And when you're given such an illness, we know it's going to be shorter than most. Right. Live like you were dying? Well, in a sense that you want to still live the rest of your life, however long or short that's going to be, and you want to enjoy it. You're just trying to give someone some pleasure in their life. It might be the time in your life where you're told you can eat whatever you want. We try to discourage things like smoking and things that can hasten the death, that can cause you more uncomfortable symptoms. But we look at medications. We look at every approach to what's going to provide the most comfort. So medications that can relieve pain and relieve breathing difficulties and nausea, you know, are one thing, but we also can eliminate medications based on what discomfort they may cause. Sometimes people have difficulty eating, difficulty swallowing, all the physical components make it difficult. But we want to just be there to help guide them every step of the way. And it might be that an individual medicine we discuss with the physician and the family about stopping, just to, because it's giving them side effects or some discomfort.
What we're going to do is we're going to take a little bit of a break, and when we come back, maybe you can tell me what the people on your staff do, the actual, as opposed to just the nurses coming in to give me a shot, what each individual does. So we come back, we can talk about that.
Thank you.
Thank you. Thank you. Sounds good.
I recently lost a dear friend who had a long battle with cancer, and he decided to forego treatment. And we called in hospice and we interviewed different hospice care organizations, and he decided to go home. He wanted to die at home, and he wanted to die under the care of hospice. And it turned out to be a beautiful experience for his family and for those of us who loved.
explore new worlds. Read. Visit literacy.gov.
Welcome back. In the first segment, Donna had mentioned something about the people that are on the staff and other than just the nurse, because I think maybe some people have the idea that just a nurse comes out, gives you medication, and says calm down and go away. But it's a lot more than that. Could you kind of tell us about the different type of people that work for hospice services and
Sure.
what they would do in the house?
Besides the nurse that does provide intermittent care and services in the home, especially in the home, we have nurses on call 24 hours a day. So there's always, even if we're not in the home all the time, we can be called at any time, day or night. So the nurse is always available to provide the support to the patient and family. But in addition to that, we have a social worker. The social worker will come in and evaluate the home situation, see how they're managing together. Are they requiring additional help that they're afraid to provide themselves? They go over the services that they might require. It might be something else in the community like homemaking service or things that the state might provide and different insurances might cover. But in addition to that, we have volunteers that are part of our hospice team, and sometimes the family needs to go out for their own appointments or just to run their errands and the patient can't stay alone. They can sit with the patient. They can provide conversation, comfort, music therapy. I've had people write journals. Some of the volunteers go in and write journals for the patients that they want to leave information behind for their family. The social worker can help with that kind of thing too, do a life review with the patient and family, looking back at their life and showing them how their life counted. And they also want to be able to leave some information behind for their family. When life is cut out short, quickly on someone, you don't get to have that whole grieving process. You don't get to say goodbye. You don't get to settle some issues. And both the volunteer can help just be a sounding board. The social worker provides some counseling, but we also have, whether it be a spiritual counselor or a chaplain, that can provide some of the end-of-life issues, religious components that people might have fears about. Also, we have a bereavement coordinator. That person in our agency has control of the volunteers as well. She organizes their schedule. And the bereavement coordinator will provide some of that emotional and spiritual support, but they also follow up with the patient 14 and 15 months after a patient passes away with the family to help them cope as the time goes on. Through the time of the care of the patient, it can be very stressful. The caregiver needs to be helped as much as the family, as much as the patient does. And sometimes the family or the patient is fearful about one another, that they're a burden on each other. And we want to provide that support around that as well. Our supportive services can give the family a break now and then so that they can run their errands, take a walk, get some rest, whatever it might be, to gives them time to recover and continue. Sometimes we're just a sounding board,
Somebody to talk to.
Yeah.
That's right.
We have nurses' aides too. I don't want to leave them out. They provide help.
Put them all in there, whatever you got.
Without
pet sitters is fine too.
Okay.
Whatever you got, whatever you hate, that might work.
Well, a lot of people need personal care, obviously, and as their condition declines, they're not as capable of doing it themselves, and so. And sometimes the family has difficulty if it's your mother or your father. You're not as comfortable providing personal care, which can be very intimate. And we have nurses. Sometimes we just will teach and instruct the family on how to provide that kind of care, whether it's positioning, transferring, walking patients, and some of the personal care. We're either instructing them to do it themselves when we're not there, because we're not there 24 hours. If we had a condition of a patient that we couldn't manage those symptoms at home, family was having more difficulty. There are different aspects of hospice also. When I talk about home hospice, we're doing that in a patient's home. We have some patients that go to nursing homes, and we are an adjunct to the nursing home staff to provide the end-of-life care that hospice provides. We can bring private nurses' aides to go in there to give them a one-to-one attention even when they're in a nursing home, and that's still in addition to what the nursing home provides. There's also something called respite care. If the family, for a short period of time, I've had patients where the family had to have surgery themselves and they can't leave their loved one alone. Respite care is something that certain insurances will cover in a nursing home for a few days period of time.
You know, I'm looking back and I'm thinking of, like, you know, my mother and my father and maybe my grandparents, okay? Your family, someone in your family's sick. It's your responsibility to take care of them. You know, so it's almost like I have to be the one that's here. I can't have anybody from the outside come in because it's my responsibility to take care of them. Which might be nice if that you could do that yourself and you knew all about these things. But, you know, the person that really does know what's happening in this situation, it's like, you know, if your car breaks down, oh, you got to fix it yourself. No, I'm going to bring it to a mechanic because I don't know about all these things and what is happening, whereas you do. But I know that, fortunately, I think in this generation that's coming around now, people understand that, that you can't just be there for them all the time. It's impossible. Like you say, they want to go outside and walk out the door. You can't just say, well, no, this is it. Now that your family member is sick, you must be at their side all the time and everything else. Quit your job, do what you have to do, and so on and so forth. And meanwhile, you know, there's somebody out there who really knows what can be done in this situation, and you're reluctant to do that. Do you find you get resistance to some people in that, you know, we don't really need you, we'll take care of this ourselves? Or
well, definitely. Sometimes it's the guilt people feel that they need to be there all the time, or they just want to be the one. They've committed to that person, their husband or their wife, and they feel that they need to do it. And it's just allowing us to go in and provide that extra help, giving them their privacy, giving them some time and to renew their own strength to be able to go on. You know, and it is difficult.
Yeah, I know all about guilt. I'm an Italian, so I know all about guilt. But even if you are doing that, you sometimes beg, should I really be doing this? But I think I know that it does help myself from personal experience. You're reluctant to do that. I can do this myself. But it comes to a point where you just can't. Thank you. See, it's not just the nurse coming in to give them a shot once in a while. There's more to it than that. All right, we're going to take another quick break, and we come back, we'll kind of sum up what's going on here and get that together. Thank you, Donna. Thank you. Okay.
I recently lost a dear friend who had a long battle with cancer, and he decided to forego treatment. And we called in hospice and we interviewed different hospice care organizations, and he decided to go home. He wanted to die at home, and he wanted to die under the care of hospice. And it turned out to be a beautiful experience for his family and for those of us who love him.
Hi, how are you doing today?
What looks good?
Our special today is shrimp scampi. It's been sitting around for about a week.
Excuse me, what time are you guys leaving? We're gonna rob your house tonight.
Don't you wish there were warnings to protect you from life's risks? With diabetes, there is one. It's called A1C, a simple blood test that helps measure your risk of serious complications. Learn more at diabetesa1c.org.
I want to ask Donna about the timing of requesting hospice service or identifying when it may be required or at least looked into. Can you give us a little ideas about, you know, when you would begin doing this, or what prompts you to do it?
I think there's a misconception about hospice in general, that people think that it means their life is over and that they don't have any time left, or they have to wait until they're actively dying that they need to go on hospice care. And when I've tried to describe what the other supportive services are, it's because I want to make sure people understand that at the end of someone's life, it doesn't mean the last hours and days. It really means it could be to qualify for hospice, the doctor might say that you have less than 6 months to live, and that is a requirement when you first go on hospice under most insurances. But it doesn't mean that's how long you have to live, because no doctor is going to predict exactly how long you have. Okay, I often tell my families when the doctor makes that decision that you have 6 months or less, it's because your condition is such and the decline is such that it's not surprising that you may not live past that time. But we've had patients on longer, year and a half, 2 years sometimes, and people can even go on and off hospice if their condition stabilizes for some reason. It's just that we want to make sure that you have the time to prepare. When someone's life is snuffed out very quickly, no family member, no patient has the time to prepare. It's over. And you haven't had the time, and I've said this before, the time to say goodbye, the time to prepare each family member for the end of someone's life, to say the things you want to say to your loved one. And like I said before, making your life count. You know, when we've had people want to just leave some kind of legacy, you know, some people want to leave their money. Sometimes they just want to leave their words and give their advice. You know, I've had some family members where, because they had time to do that, they've had, I had one young woman and she had teenage children, and she and her sister and her husband prepared for all the different times that their children would face after she was gone. So it gave them that time to prepare for that, to have talks about it, to even enjoy together discussing their graduations, their weddings, and things like that, you know, and giving their words of advice to their loved ones to carry on. Sometimes it's a husband or a wife that wants to make sure that the family left behind is going to be okay, you know, so you want them to have that opportunity to say the things they need to. But it really is important to sign up to hospice sooner than later, because it's going to give you that time to do all those things.
And you see, I'm funny. I'm funny. Funny. I'm looking for the behavioral aspect of this thing. It's not just, oh yeah, you can overcome this physical disease by you know, doing something in the mental section. And I don't necessarily believe that, even though some people say, yeah, it works. But it's how you deal with it along the way that makes a difference. And patient and family members and people who. But you do report these things. In other words, you're with the family and you're doing this. You report back to the physician as to all the progress on this as far as things are going. Not just, you know, the vital signs and everything else, but the environment that they're living in. And
absolutely. I mean, whether it's their safety or their symptoms or the home environment, there's a whole synopsis of a report that's given to the physician. We also meet on a weekly basis. We have a hospice medical director. Every program has to, and that's a physician. And you know, our director meets with us on a weekly basis. We discuss the cases as a team so that any problems, unusual problems that arise, sometimes people have great difficulty coping, just like you said, and we do have the experts that know their limitations and when it needs to be referred to a counselor or psychiatrist or their physician even, to be able to cope with the situation. You know, sometimes you find yourself, when I went through, you know, situations in my life with that, I found out that I didn't want to eat. You know, I couldn't eat. If I get depressed, I don't eat. That's the way. And I said, this is crazy. You know, I'm going to get sick with this thing. You know, and that makes a difference. And I know that if I were in the position of the identified patient, that I really would be more upset if my family members were going around, you know, and not having it all together for themselves. You know, it'd be difficult. So. Well, you know, I'm really glad you decided to come here tonight, because I just want to, since I've had to use your services myself, and they were great, by the way, and you guys were a great help to me and my daughter and my in-laws and everybody else in this situation. We didn't know you existed in that case. You know, I mean, like I said, I thought hospice was this place down by the shore that you sent people that had a few weeks left and they were just going to be there instead of somewhere else. You know.
But you do provide a real service, and I can see you. You do more than just give medication.
Mm-hmm.
Okay, you provide for the well-being of that person. Makes a lot of you. I thank you very much. This was really interesting.
Thank you for
I
having
like doing
me.
this because I learn things out of this too. This is tremendous, and hopefully we've been of some help to you, and
Yes,
hopefully we've been
thank
some
you.
help to you. See what's happening. Thank you again.
Hey,
Good to
thank
see you again.
Same here.
All
Thanks,
right,
Frank.
take care.
Hey, how's it going?
Sir, are you okay?
What? Oh, this? It's probably nothing. I'm sure it'll go away.
Go away? But, sir, that can't be good.
No, it's cool. Really.
Do you want a napkin or something?
Everything's fine. Thanks.
You wouldn't ignore this. So why ignore the signs of a stroke? At the first warning signs, call 911 immediately. Because time lost is brain lost.
In the event of a car crash, 3 out of 4 kids are not as secure as they should be because their car seats are not used correctly. But the latch system makes it easier to get it right and to hold your kids tight. Anchor, tether, latch. Learn more at safercar.gov.